Is now, yeah.
Hopefully not.
It was good publicity for Tim. Hi, everybody, and welcome to the Primary Care Commissioning Committee this afternoon. I hope you're all well and enjoy the sunflowers in Tim Maycock's background picture. And please visit his Just Giving page. Not that there's any publicity going on there. Right then. If I start off with apologies, and we have a few today. One is from Paula Evans, and the other one is from our lay member colleague, Phil Gertley. And I understand that Andrew Moriarty will be joining us later. He's got a meeting clash at the moment. If I go straight to declarations of interest, if there are any declarations of interest, if you can raise them as we go along, and then we'll deal with them accordingly. Okay, thank you. If I can ask you all to, and I'm sure that you've read the minutes of the previous meeting, and if we can just agree that they're a true and accurate record. I'm looking for nods. Yeah, yes, thank you, Michelle. Yes, we have. And then the next part is matters arising. And what I'm asking, it really is for updates on them all, if possible. So Fiona, the first one has your name near it. And that's around the 3-month social prescribing impact report. And I know that we've deferred this. So little update. Sorry, you're on mute. Sorry, you're still on mute, Fiona.
Apologies, Julie. Yeah, it kept getting deferred because of obviously system pressures, but very happy to bring something back to any of the future meetings if you just let me know when you'd like something. They're currently re-evaluating the impact of the social prescribing roles at the moment, so we can have something more current for you over the next couple of months if you'd like us to bring that back.
I think that'd be lovely because we're hearing some really positive outcomes, so I think it would be a real prudent time for us to hear some really good news, don't you?
Yeah, happy to do that.
Lovely. Then the next one is actually part of the meeting. That's around the medicines management. And the practice boundary one.
Sorry, Julie, I'll bring that back to the next meeting. Sorry,
brilliant. Lovely. That's okay, that's fine. It's just that I looked at the matters arising and just thought it was good. It's good practice sometimes when you're in a bit of a state of flux to sort of clarify everything. And Sean, my next question's to you. Really, it's PCCC 58 and it's the primary care dashboard. And I know you have updates for us on that.
Yeah, I can give a quick update on that one. So at the end of July, Dave Eiley and myself were invited to a meeting with LMC colleagues, which was helpful in terms of a sort of joint aspiration to try and get a bit more of a handle on some of the primary care demand data. So working with Brian and Andrew, the aim is to link in with some of our practices who are using clinic in the first instance and try and access some of that data so that we can look at that issue that we raised beforehand of understanding a bit more about practice appointment types and which types of clinicians we're seeing, which types of presentation. So that work stream will develop with involvement from LMC, which I think will be really helpful in terms of engaging with practices. And when we get some data, we'll bring that back to a future meeting and include it with the primary care dashboard if that's appropriate.
I'm thinking we may have lost
Sorry,
Julie.
have we lost Julie?
We have.
I didn't think I'd stunned you all into silence there. Technical problem. Just wait and see if Julie comes back.
Okay, so shall I move on to the meds management flowchart? It's an agenda item under a matters arising, or not? What do you want to do?
I'm sure Julie can catch up when she's back. So yeah, I think rather than radio silence, we should go forward.
So if committee members remember, it was some time ago. I'm going to have a punt at maybe 9 months ago. Laura very kindly shared the emerging medicines management flowchart, and we had a few comments on that, and the clinical leadership group for pharmacists went away and looked at that and just made sure that we could implement a similar process across the whole of the patch. So that's been agreed, and it did go to QPEC 2 weeks ago and was approved there, and that's what we agreed would be the process that QPEG would approve, and it's here for committee members just for information. So I'm happy to take comments if anybody has anything, but as I say, it's really for information. No, good. Okay, thank you.
Okay. We still lost Julie.
We have finance report next on the agenda item.
It is. I'm happy to kick off. David, I guess you're the only lay member left. Are you happy for me to start in Julie's absence? Or
Yeah. Let's keep going, I'm sure. There's nothing on my phone, so yeah, we'll just keep going.
Okay.
If you can, Simon, thank you.
Yeah, of course. Thanks, David. So this is a month 5 report. Worth reminding everybody that we're reporting in halves this year. So our plan only goes up to the end of this month, so a week left. So at month 5, in this report, we're indicating a small underspend of close to £500,000 on the Delegated Commissioning budgets, and an overspend of about 600,000 year to date on the other primary care, predominantly around primary care prescribing. The forecast position is that we'll overspend on the total primary care budget by around £500,000. Within the overall CCG's budget, that's a break-even position at month 5 and continues to be forecast at break-even to month 6. So we are expecting to hit our half-1 plan. Within the primary care field, primary care prescribing, as I mentioned, is the most significant overspending area. We've instituted an increase in capacity to the prescribing team to help with easy and straightforward medicine switches, with a view to trying to make some impact on that this year, some impact on the overspend. Other than that, not much to report, other than for everybody to know that we still, as we sit here, have no indication what the financial settlement will be for the second half of this financial year. So that's the period starting 1st of October. And there are still fairly significant elements of the funding for the second half of the year which are out with that settlement. So significantly the hospital discharge programme and the elective recovery fund. And it is likely that there will be some changes to the administration, the operation of those schemes in the second half of the year, but we don't know what they are yet, as the guidance has not been published. So I probably wouldn't want to say too much more than that, David. It's a pretty straightforward report at month 5. Everything looks like, in the overall CCG terms, it's where we would want it to be. Primary care prescribing is the big issue for the primary care committee to note.
Okay. Could I just ask Simon, what in terms of the kind of delegated commissioning, what will happen as we move forward to the ICS? Will that just all of the collective delegations will probably arrive on an ICS desk?
So I think I'm right in saying all of the CCGs in the Humber Coast and Vale have delegated budgets for the GP element of primary care currently, and we would expect that would continue into the ICB. There is a process to review how the ICB might look to take on further responsibility for dental, pharmacy, and opticians, ophthalmology, community opticians. That won't happen from the 1st of April, we don't think. It could happen partway through the year. I think October 22 will be the earliest, but certainly a move from NHSEI to increase the level of delegation down to the ICB for primary care services.
Right. Okay. So that could be a big change. Okay. Any more questions, comments on finance? No. Okay. Let's move on to an update, which is item 6, which is an update about primary care networks. Fiona and Gary, I think. Who's going to lead on that one?
Gary, do you want to start with Central?
Yeah, happy to. Yeah, so just reflecting back in May, we commented that Central PCNs felt that they had achieved that NHSE model for primary care in York with Nimbus as their at-scale provider. I'm going to share some updates on how I think that clinical leadership has translated into transformed service delivery and also responding to kind of COVID and some current system pressures. So very briefly, I'm going to cover off a little bit about the OD plans, a little bit about the COVID hub that's been running since the onset of COVID, a little bit about the Pediatric Respiratory Hub, a little bit around OPAL 3 reporting and managing urgent care in particular, and then finish with a little bit around SMI. So in terms of the OD plans, all 5 PCNs in Central have completed their plans. There's some common themes. They've all done a little bit of review of the benefits arising from last year's funding, an indication of how that funding was used and how it's developed their PCN. There's a bit of a context for what they're going to use the 21-22 funding for. Predominantly, they're about recruiting new posts that are either project management or performance management, or taking a more strategic view on workforce planning, all focused around supporting the recruitment and rota management, ergo access, for these new additional roles. There are common themes about developing their BI capacity, IT, finance, and quality improvement at a strategic level, which I think as you work through the PCNs, it reflects the maturity of each PCN. There's also quite a lot in there about purchasing clinic or Ardens as well, around improving the delivery and consistency of coding. And I think the ambition is that all 5 Central PCNs are planning to use clinic by the end of this year. So we should have, I think we should have clinic across the board. There's quite a lot as well around training and mentorship, very much around supporting these new roles to embed quickly and also to ensure that long-term retention of these staff as they come in. And I think broadly that kind of identification and reduction of health inequalities, together with the leadership required to manage themselves collectively and their system partners within York as a place, comes through very strongly. So those plans are ready to go, I think. In terms of the community hub, we've spoken about this before. It was set up by the PCNs with CVS in response to the first wave of COVID to identify and support patients at high risk of rapid decline. It's then gone on and supported PCNs with pulse oximetry, BP at home, very often been the first point of contact for new positive COVID tested patients, including for a good while actually students, while the universities and colleges got their wellbeing teams established. And it's also worked with health trainers to support patients improve their post-COVID health. And that overall theme rings through with what the Hub is doing now. So looking at long COVID, we've had some funding agreed in principle to support patients in that long COVID pathway, especially between the GP referral and the patient attending their first MDT assessment. We know that not all patients fill out that self-assessment in a way that makes that first MDT assessment as good as it could be. So there's some support to go in there. And we also think that as that long COVID pathway gets established, the service is more than able to evolve and support patients after that MDT assessment. But we'll, as that pathway establishes, we'll see what the need is. We're also having a bit of a discussion with the through the Regional Waiting Well Programme Board to think about how the Hub might build on kind of this. It is an established social prescribing with clinical support. That's what the Hub essentially is. And then how we might use that basis to begin to work with patients on the very long waiting lists, particularly those who are risk stratified as being at most risk of deteriorating health. So there's a bit in there about supporting the patient's emotional well-being, and as well as being important in its own right, the intervention that we're talking about is designed to support patients to maintain their ready for their operation status, if you like. So for example, and in particular about managing BMI, if you're going to wait maybe up to 2 years for your hip and knee to be replaced, only to find that your BMI went up as your emotional well-being went down, and your BMI is raised to a level where you're outside of that threshold, you might have to wait another year while you re-optimize your health for your operation. If we can avoid patients having an extra year in that waiting list, then we think that's a good thing to do. So it's very much funding dependent, but if we get some funding, it will be maybe a 3-month pilot basis with the aim of sharing that learning across the ICS. On the Pediatric Respiratory Hub, thank you, Steph. I see that's in York Press today. So if you read York Press, you'll probably get a better and more exciting read-up of what that is rather than what I can give you. But again, the PCN's working through Nimbus with a broad range of local GPs, the paediatric consultant leads and nursing leads at the Trust have worked together to shape a GP-led pilot to provide a review service for young children with bronchiolitis. It starts on the 4th of October, it's going to run for 8 weeks, and then we'll take the lessons learned and share that across North Yorkshire as well. It's going to be based at Askham Bar. We love an acronym. The Pediatric Ambulatory Treatment Hub conveniently becomes PATH as an acronym. But it is another example for me about why that mass vac site is and will remain important as a primary and community care hub for York residents. In terms of staffing, it's being staffed by a GP, an advanced nurse practitioner or advanced clinical practitioner from general practice, and a paediatric nurse. And then all the consumables, oxygen, etc., are being provided by Nimbus. The service will see patients from York, but also outside of York. And these are patients who would have otherwise accessed ED. I've got to say as well, I think the whole project between James McQuillan and Karen McNicholas within the CCG have done an absolutely fantastic job of facilitating this from beginning to end. And there's a reason for saying that. So this 8-week pilot, York Trust are providing their paediatric input at nil cost. Nimbus are providing the GP and nursing input at nil cost. The site is at nil cost, all the facilities, including the oxygen, at nil cost. So the cost to the system is being borne by the providers, not the CCG. And I just think it's a superb piece of that kind of integrated collaborative working. I also hear on the grapevine that both in the paediatric team and in general practice, the enthusiasm for it is such that they've had no problem filling the rotas. And there's actually queue of people that if anyone drops out of filling the rota, there are people to step in, which I just think is, it speaks volumes about putting the needs of that patient first and the enthusiasm in a tired workforce that can generate. Just coming to kind of urgent care and a bit of mutual aid. So we spoke, I think, again in May about our concerns about primary care resilience as we come out of COVID. And of course, what we've seen is the whole system, be it health or care, is struggling with resilience as we sit here today. In response to this, the PCNs in Central have kind of worked to provide a mutual aid for practices reporting OPAL 3. Now, OPAL 3, for those who don't know the OPAL system, that is kind of when you're approaching the point where your clinical and patient safety is considered to be approaching at risk. So it means that the practice will be under a huge amount of pressure. And what the Improving Access Service has been doing is providing additional sessions at the end of the day that practices at OPAL 3 can book into over and above their normal quota. And really, this is about keeping practice staff, clinicians and patients safe at times when some of these practices have been under extreme pressure. And then there's been a bit of building on that. So Nimbus have submitted a proposal to provide some additional kind of primary urgent care this winter across the York and Scarborough footprint. And Vale of York CCG, together with North Yorkshire CCG, have been leading some discussions on how that additionality, those GP sessions, could become fully integrated within the existing urgent care services. And if we're able to progress it, it'll be 8 a.m. to 8 p.m. Monday to Friday, with a specific aim of decompressing those York and Scarborough EDs. So very much work in progress, but it is in progress. I'll just wrap up with a little bit about SMI. So again, back in May, we reported that I think York Medical Group had achieved 94% on their LD health checks. And a bit of learning from that, and again, support from Sheila Fletcher, in particular within the CCG. The PCNs have developed, again through Nimbus, this model for an enhanced, I'm going to read this, an enhanced multi-agency collaborative approach. Gosh, what a mouthful. Working together to sort out the SMI follow-ups and bring those personalised care plans up to date. So practices are identifying patients on their register now that have got incomplete checks, beginning to call them in, complete the checks and update those personalised care plans. And then the routine checks are going to be carried out in a mix of environments, including GP surgeries and pop-up clinics, community venues, again, including Aston Bar. And the aim really is to bring the practices together to work more closely together with one another and with partners. And the partner list is interesting because you've got CVS, you've got the council health trainers, you've got the sport and active leisure team involved, the local area coordinators, and the voluntary and community health teams as well. And the new primary care mental health roles are kind of important in this because they will then link into that work and create the opportunity to work more closely with CHUV to identify patients who are being discharged from secondary care and make sure they're on the register and within the loop. And I think broadly, you look at the aims and it very much builds on that health and care alliance approach that feels very strong within the city. And it's also aligned to the community mental health transformation programme. So just to close, I think, looking back over kind of the whole, since the advent of PCNs, really, it's really been embraced across central practices. They're working so closely together. I think they're displaying some individual and collective leadership across the system that is stunning at times, supporting patients, supporting practices, and also supporting and enabling that wider system working. And just referring to the OD funding, it's a relatively small amount within the whole PCN resource, but it plays a really important part because it is maintaining and developing leadership at all levels through the PCNs. And I think that in turn allows PCNs to work much more collaboratively with each other and with system leaders. This is, as a report on what the central PCNs are up to, it's been a real pleasure to give. Thank you.
Okay.
And I'll just do a really quick summary for Vale, because I'm conscious of time. Similarly to the city, I guess, Vale continues to focus on reducing inequalities, and they've certainly embraced the additional roles that they've been able to employ to have that focus. Julie mentioned this at the beginning, and we'll bring that report back, but the care coordinator and the social prescribing link worker posts are getting national recognition now from the Vale for the work that they're doing around supporting vulnerable groups around dementia and frailty and mental illness. We've had podcasts published nationally on the Ockham healthcare site, which is really well utilised by colleagues across the NHS, and Selby have been showcasing their work through that, and also through the population health management work that we've been doing in Selby. Again, that's been showcased with Optum on their national websites as an exemplar of how things can be delivered across communities with that partnership working. So some really strong success stories around the difference that care coordination and social prescribing is starting to deliver, which is really nice to see, and nice that that's been recognised, I guess, outside of our own system. Lots of work, as Gary said, around trying to improve our uptake of checks for some of our really vulnerable groups with learning disabilities and serious mental illness. And just want to commend Pickering particularly for having the highest rate across the CCG for the work that they've done on enhancing those health checks, which is really nice to see, and we're sharing that learning across the Vale. Some of the practices are well up into the 80% mark for that, which is fab, but there's some quite wide variation across our practices, so we're now trying to focus on standardising that success across all of the practices. As well as the additional roles, lots of work with partners, which I think is really key, and a symptom or a sign, really, as Gary says, of system maturity, I think. So we're piloting dietitian posts with York Trust to support care homes in Selby, and we're also piloting a new occupational therapy post in Southam and Rydell to focus on end of life and palliative care. So these are roles that traditionally, through the additional funding, haven't particularly been embraced by PCNs, and it's really nice to see that wider therapy role becoming such a strong part of that primary care team and that primary care network. OD plans Gary mentioned, and compared to last year, the funding is fairly small. It's less money this year for the PCNs than it was last year. So, for example, Selby Town had over £38,000 last year, and it's down to 25,000 this year. So, quite big drops for them to deliver their significant OD ambitions, I think. But key focus for all of them are on system maturity and working in partnership. So, range of projects across the Vale that are focusing on urgent care and on mental health, and also on some of the frailty work as well. So the OD money will be about providing clinical leadership for some of those system and partnership roles. In terms of mutual aid, that's similar to the city, but delivered in a very different way, because sharing resource across rural geography is really challenging, particularly in Shah, where we've got 600 square miles to try and cover with our 7 practices. So they've particularly been looking at things like improving access and extra sessions to provide additional support, and that seems to be going well. The Vale practices traditionally have less patients attending A&E, partly because of the geography and the distance, but there's a lot of work going on around urgent care in the Vale system. So Selby are looking at how they redesigned the urgent treatment centre for Selby district residents, and Southam and Rydell have embraced the new posts that the CCG approved, some of the paramedic roles. So we've got the first of 2 paramedic roles already started since last month, which is fantastic. And we're aiming for the other practitioner to start in October, with 2 more roles due in April. So that'll be a really significant contribution for managing urgent care and keeping people safely at home in that rural geography. So really grateful for colleagues who've helped make that happen. I think our big challenge, just to finish off now as we move more into an ICS system, is how we maintain all of this work on inequalities with the huge demand we know primary care are under, and probably some nervousness, I think, as we move into a bigger North Yorkshire system about how we make sure we keep that really strong Vale voice in a system that's so much bigger from a geography point of view, and really keen, and the clinical directors are really keen that we don't lose that focus on place and local needs. So working really hard with colleagues to make sure that voice gets heard really strongly, and that they're able to carry on that ambition of delivering what matters for their places. So some really great examples of ongoing service development, ongoing service improvement, and lots of great collaboration, which is allowing us to test some really new and innovative roles across that patch. So hoping that will continue as we move into winter and manage that extra demand. But some great examples of a system that's maturing really well as partners start to work together.
Okay, fine. Thanks for that, Fiona. Any questions or comments? Lots of interesting stuff there.
Sorry, David, just a quick question. Gary and Fiona and Tim might be able to answer it as well. Do you feel that patients are sort of embracing the additional roles, or is there still a view that they're sort of insisting on seeing only the GP, or do you think there's patients are getting used to the additional roles and what they can offer?
Do you want to comment, Tim, firsthand? I've got a view.
David, what percentage of honesty do you want?
100%.
Go for my normal
100% from you, Tim.
Yeah, okay, so 110%. So the patients haven't got much of a clue what's going on with PCNs. It's another acronym. They don't fully understand much about them. And why should they? They just want to access care from their GP like they've done for many years. It's a slow process. Where I can only speak for Parkington, but we're quite a traditional conservative area with a small c. So there's a lot of work needs to be done to encourage patients to access these roles. So very much, particularly with things like the MSK physios as first port of call, we will kind of do an introduction. So they're still needing a telephone call from a GP, and often that's done with our duty system, but we're able to signpost them to the physios and explain it. However, some of the younger patients are sort of taking that service and adapting to it more quickly. So I suppose it's more with the elderly population. And what we're very careful we don't want to create is kind of like an unconscious discrimination, so that the young, technically adept people are navigating the system much better than some of the elderly people who may have more need. So it's slowly, David, like everything, change has to be managed. And I think when we pat ourselves on the back and say it's successfully done, that's when we're setting ourselves up for a fall. So we've got to be on it. But I can start to see the green shoots of that change. The only caveat I'll say is it's not taking pressure off general practice. It's improving the quality of service, and it's possibly reducing the wait to speak to a GP by a day or two. But I don't have any free appointments as a GP. I'm booked up for 3 weeks, and there isn't any less demand. We're just offering a better service. So if the physio takes away a few MSK cases from me, they're filled with something else. GP is at capacity and overflowing. So I think we have to be careful to assume this is actually going to relieve pressure. It's just giving patients a better service, which I'm all for, but it isn't going to reduce demand on general practice, and it's unlikely to have a serious impact on wait times to see a GP or speak to a GP, which I believe are currently running at about 3 weeks throughout our patch, whether you use clinic or not. So it's definitely positive. All investment in primary care is welcome, but it's not the finished article yet, so we've got to really be on it as clinical directors and PCNs to make sure we get maximum value. And it is this relationship we have with the public of how the NHS is judged, because there are so many different angles in, so many different avenues to access it. How do we get that consistency of approach? So obviously I prefer that to be through our local general practice working with the community, which is what we're doing in Parkington, but I appreciate you need a different model for a big city like York. So yeah, it's positive, David, but it kind of comes with caveats, I suppose, as you'd expect.
Yeah, thanks, Tim. Thanks.
As we said, well, and a little bit on the back of what Tim says, we know that these roles aren't fully embedded in the public psyche yet, because we're still actively running comms to make patients aware of what these roles are, and that there is an alternative to a GP located within the GP service. So I think kind of very much aligning with what Tim's just said, on the day we decide we don't need to run those comms out on a regular cycle, that might be when we say, yeah, it's so embedded in the public psyche that it's now and it's. But if you go back, 15, 20 years ago, when practice nurses were definitely in the minority in most practices, and it took a while for general practice and particularly the public to kind of take the fact that practice nursing was an alternative to a GP for managing your long-term condition in particular. So we know that these things take time to embed, but I would say on the whole, it's been really positive. But it does create other pressures, not least on room space, rota management, clinical supervision. So it's not just a straight, an extra hour in is an extra hour freed of GP or practice time. It creates a different set of pressures, but they're good pressures to manage.
I think, Dave, your question was, has it been well embraced by patients? And I have to say, in the Vale, they really have. They absolutely have. And I don't know whether that's because they focus more on some of their perhaps more vulnerable, frail groups, which certainly for the Vale tends to mean the older population. They have really embraced the care coordination roles and things where they've really valued having more time to spend with somebody, and somebody who can look at all of their needs rather than just a particular condition. So we haven't had any problem at all getting encouraging patients to work with the additional roles, but perhaps that's maybe because we've had a slightly different focus because of our different demographic. But yeah, echo Gary's point that actually we're not far off being a victim of our own success in terms of where do we put all these extra posts, and his state is really challenged, and it is putting a big pressure on practice teams to provide the line management and the clinical support for all of these additional roles. So yeah, there are challenges with them, but I have to say they are being exceptionally well received, and we've got some fabulous patient stories in terms of the difference it's made because they have more time with those patients.
Fine. Okay, thanks very much.
Thank you.
Any further questions, comments? Well, thanks, Fiona and Gary. Very interesting new developments going on there. Let's move on to item 7, Steph, which is the COVID-19 update. We're hoping for some good news.
Well, there is some good news, yes, indeed. I'll start on the vaccination process, and I will just catch up on the infection rates per 100,000, but we have the pleasure of having Sharon Stoltz here, so we'll defer and ask Sharon if she's got anything else to comment upon. But so for the Vale of York, in terms of the vaccination rates, first and second doses, first doses we're moving towards 86% of the eligible population being vaccinated, and we've hovered around there, not making any sort of significant surges up to 90%. But what we are seeing is the activity of the second doses coming up. So just to remind people, you get the best protection from that first and second dose. And we're now in primary care moving towards a third dose offer. Some people may have already had that third dose, particularly if they are immune suppressed. But our local vaccination services are starting that work around the third dose. So importantly, your third dose comes no sooner than 6 months after your second dose. So you'll be invited forward either via a text from the National Booking Service, and then we'll move down the cohorts in a similar way that we did when the programme started. So we're starting with our care home residents and the staff, and then we'll move through clinically vulnerable and people who are over 50. So just to remind people that they'll be invited in, but no sooner than 6 months after their second dose. So in the national press, people may be aware of the universal offer to our younger residents, our younger citizens, so 12 to 15s. Primary care aren't leading that. Our school immunisation teams with our schools are delivering that service, and that commences in our area in York, North Yorkshire, next week after a huge amount of preparation for that. So I think we are fairly well versed now in delivering those services, and obviously our pharmacies, our practices are also now starting to call people forward for their flu vaccines. So COVID vaccine, flu vaccine, always subject to supply, but it's really important now more than ever that people make sure that they are vaccinated as we move into the winter months. So in terms of our COVID infection rates, they're per 100,000, they're down at 173, though the latest figures that I had yesterday. And before I invite Sharon in, I just want to highlight to people, our staff, anybody else listening, and we do have a special focus on outbreak management via an outbreak management board that's headed up by our council colleagues, and the next meeting of that is the 29th of September. So in the same way that you'd access streaming services to listen and get a greater level of information and detail around that, you can do that. That's a 5:30 start on the 29th of September. So I'll just invite Sharon if she has any additional things she wants to say.
Thank you, Steph. I mean, I suppose it might be helpful just to give a bit of an overview as to where we are with COVID case rates and what's happening in care homes and schools, etc. So our case rate has been broadly steady at around either just under or just over 200 per 100,000 for a little while now. But that still represents over 400 new cases of COVID every 7 days. So the most recent data takes us up to the 20th of September, and that 7-day period, it was 403 cases. So, you know, COVID is still with us. We are still in stage 4 of the pandemic, and I get very frustrated when I hear people say that the pandemic is over. It certainly is not over when we have that many new cases of COVID every week. In terms of where we're seeing those case numbers, we're seeing the highest case numbers at the moment in younger age groups. So you're looking at 10 to 14-year-olds and 15 to 19-year-olds. By far the highest rate and the most cases we're seeing are in secondary school aged children. And we have a number of outbreaks across schools in York at the moment, which isn't just the case in York, it's the case across the whole of the country. Not unexpected. We expected cases to go up with schools opening again. Obviously, it's fantastic news that secondary school age children are now going to have access to COVID vaccination. And my understanding, Steph, is the aim to have offered all children between kind of 12 and 15 a vaccination by October half term, which is quite a challenging target to meet. We are seeing an increase in the number of cases in residents over 60. Our rate is lower than the regional rate, but it's higher than the national rate in over 60s. And we're also seeing a steady rise in hospital admissions due to COVID. So, you know, still quite a lot of activity there. And we're still seeing COVID-related deaths. Certainly lower numbers than we've seen at previous stages in the pandemic. But, you know, I'm talking about York here, not Vale of York. But I was on a meeting with North Yorkshire colleagues today, and across North Yorkshire and York, we are still seeing some deaths due to COVID. I feel my heart goes out to those families really that have lost a loved one to COVID, and then they hear people saying that the pandemic is over. It's got to be quite difficult for them. In terms of care homes, we're doing reasonably well in York. We have 4 care homes with cases of COVID at the moment. It's important to remember that care homes are doing routine testing of staff and residents. So even though cases are being picked up in care homes, we're not seeing significant outbreaks. And in fact, the last care home outbreak we had was on the 8th of September. So kind of a bit of a mixed picture, really. Obviously, vaccination program going very well. The vaccination program is undoubtedly having a really positive impact on deaths and hospital admissions due to COVID, which are lower than they were. But obviously, COVID is still very much with us. It's still circulating in our communities. And I would urge everyone really to certainly take up the offer of vaccination, but also still remember the importance of basic infection control measures. So regular hand washing with soap and water, social distancing where you can, and importantly, wearing face masks continue to be really important. And I would encourage people to continue to follow those basic measures to keep themselves safe. So I'll stop there, David, but happy to take any questions.
Okay, fine, thanks. Any questions, comments? Could I just ask Stefan and Sharon what, we had a finance and performance meeting this morning, and I asked the same question. What's your view about autumn, excuse me, and what's coming? What's the professional view on what the health system's likely to face this autumn and winter?
So, do you want me to start, Steph, and then you come in? So it's really difficult to predict with any accuracy, David, but what we are preparing for is a really challenging winter. We expect to see a level of seasonal flu circulating. It's difficult to predict how much flu we're going to see, because if we're able to run a very successful seasonal flu vaccination program, people, take up the offer of flu vaccination, and we see a good uptake of booster COVID vaccination as well, then that should help keep the worst of the case rates down. But there are other viruses that circulate during the winter period, and we know that because of lockdowns and people's self-isolating and social distancing, etc., that our immunity to some of those viruses that routine circulate during the winter months will be reduced. So we're expecting to see COVID circulating. We're expecting to see seasonal flu, and we're certainly, there is a concern around norovirus, and then the general kind of coughs and colds and respiratory viruses that we see every year. All of that will put significant pressure on the health system, and a knock-on impact then will be pressure on the adult social care system particularly. So we're anticipating a difficult and challenging winter, but are already working together as a system, planning our communications campaign not only to encourage people to take up vaccination, but also to help people to understand those basic measures that they can take to keep themselves fit and well through winter, and infection control messages to help prevent the spread of all of those viruses that we're concerned about. Peter Roderick, who all of you will know, the joint consultant across the council and the CCG, I have asked him to update the winter modelling report that was developed a little while ago with the latest predictions from Public Health England and NHS England on what activity we might see across the NHS this winter. So he's in the process of doing that. So once that report has been updated, I'm sure it will be circulated.
Fine. Okay. Thank you. Steph, is there anything you'd like to add?
Yeah, so I just wanted to, in the context of what we've heard today, our practices are at full capacity. Colleagues will have read in the risk report that the latest data as at June shows that we are up to activity levels that we saw pre-activity face-to-face. So it's really important that people understand the data and not the rhetoric around GP practices being open for business. They have always been open for business. And actually what is happening is that practices are generating more capacity by being able to do also telephone triage and telephone consultations across all the skilled professions that work in primary care. So we know that demand is stripping out supply. We can't generate more and more and more demand. We're working flat out, as are other colleagues in other parts of the system. So we, as Sharon says, we expect access into health, into all the areas to be tight at points, challenging at points, and we are looking at different ways in which we can offer support to people accessing services. So you heard Gary talk about the Pediatric Respiratory pilot scheme, so a way in which we can support parents with young children to access services when they need to, without going to the emergency department. So yes, it's going to continue to be challenging in primary care.
Yeah, it looks like a difficult winter ahead for everyone. And as we were saying this morning, that given the funding issues about future planning, it's going to be a very difficult time for everyone. Okay, any further questions about COVID? I'm sure we'd all prefer not to hear the word again, really, but that seems very, very unlikely, doesn't it? Okay, well, let's move on. We've got an interesting item, Steph, now, Afghan refugees update. And I know that this is just a kind of in confidence report and not to be sort of questioned or repeated. Is that right?
Well, it's not necessarily in confidence. It's just very high level at this point. So across our local system, all health providers are working on the Afghani refugee resettlement scheme. So that's the permanent allocation and residency for people entering our city, York's a city of sanctuary, and we've been working, and primary care have been working on this scheme for a period of years. Most notably our Syrian refugees who we've embraced and welcomed into the city. Because of COVID, York had a temporary accommodation arrangement for asylum seekers, and the city GP practices responded to that really well, and that service was with us for probably about 11 months. more recently, we've been working with our partners on the permanent residency scheme for Afghani refugees, and making sure that services are in place as we start to get permanent residents in the city and in the Vale. But what I just wanted to highlight more recently, and particularly coming on the back of what we just talked about, which was the demands in primary care, I just wanted to highlight that with probably about 10 hours notice, we were notified that we were getting 174 temporary residents into a local temporary accommodation site in our south locality. And the closest practice had a service to deliver health assessments and support to that group of people who'd done an initial 10 days quarantine and were bussed over to us from Manchester into our south locality. So I really just wanted to highlight to the committee just how quickly partners can work and deliver a wraparound service, and to thank our primary care colleagues for doing that. I'd also want to pay a special commendation to Shamim Amim, who is in the primary care team, because together with the local mosque, Aman went down to see that group of temporary residents with Qurans, with prayer mats, to set up a faith room for them that just helped them transition into that temporary accommodation. So it's just a really poignant reminder of what our teams do at short notice, pretty much at the drop of a hat when they're doing other things. And I know that we're focused on the day-to-day business of what we do, but much like Tim with his sunflower behind him, who's out fundraising for local services, I just want people to just reflect on what a good team we've got around us, and how quickly they can pull together and to support people who are in somewhat unusual and desperate circumstances, and just reach out and support people in the best way that we can.
Indeed, good. Well, I'm sure we would all support that. What else should we be doing? So that's good. Okay, any questions, comments? No, okay. Thanks for that, Steph. It's very, very important and very interesting for us to note that. Let's move on to item 9, which is page 30 in your pack, which is the Primary Care Commissioning Risk Register. And again, you're back on, Stephanie.
Yes, indeed. But much as you'd love to hear my voice more, I'm going to defer to Sean, who's the author of the report and close to the detail.
Okay.
Thank you, Steph. So I'll just run through the risks that we have in the report currently. So we have 4. I'm going to start with the first one, which is the risk around learning disability health checks. And I'm going to recommend to the committee that we actually remove that risk now. So this is really on the basis that our practices collectively exceeded the national performance target of 67% last year. They actually came in at the end of year with almost an 80% performance against that target. So I think we are assured across the CCG that our practices are have embedded this as part of their sort of business as usual workflow now, and have made some real progress from where they started, at the beginning of 2020 with those learning disability health checks, and have put a lot of effort into developing their pathways and their processes and engaging with that patient group. So if it's okay with the committee, I would recommend that we remove that from the risk register. As part of the work that we've been doing around the LD health checks over the past sort of year and a half, we're now in a much better position with data flows, so we get a monthly update on individual practice performance against that target. So if at any point we think that there is a risk of underperforming against that national target, we can bring it back into the risk register. But for the time being, it doesn't seem to be a risk anymore. We seem to have been achieving quite well. Okay. The second one is the serious mental illness health checks. Now, we've got quite a bit of variation, I think, across the patch still with these health checks for SMI patients. So I'm proposing we leave this on the risk register. The uptake at the moment across the CCG is about 30%. I managed to get the Q1 data after this report was published. So we're currently running at about 30% against a national target of 60% for these health checks. Q1 is early in the year, so there's absolutely a lot of time for practices to catch up on this work, and indeed they may actually do some of this work later in the year rather than in Q1. So I think there's still very much time for performance to improve on this. I'm going to mention SHAR because apparently their performance at the end of Q1 is 80% against this target. So SHAR PCN are doing really well. So it is possible to work with this cohort and manage the work across the year. And just to give you a couple of examples of the work that's going on, there's a dedicated healthcare assistant to work alongside care coordinators and social prescriber link workers. Some tailored outreach aimed at increasing participation and take-up of healthcare for this cohort. A dedicated mental health social prescriber link worker post for York. And there's also work around sort of personalised health checks delivered by healthcare assistants and nurses in a way that suits this patient cohort a bit more, you know, possibly by going to their own homes or community settings. So I'll keep you updated as we progress with that, but I'm fairly confident that we will reach the target by the end of the year. The work seems to be progressing quite well with that particular area. So I'll come on to the third risk, which is on the register, which is the access to general practice reputational damage. So I think as we've already mentioned in conversations this afternoon, broadly speaking, those appointment levels are back up to pre-pandemic levels. So in that respect, the risk around access, I think, is probably somewhat reduced from what we thought, you know, earlier in the pandemic. The appointment numbers are certainly there for patients. And I think, as everybody has kind of said already, those appointments are being filled very quickly. And we're in a position where the demand is certainly outstripping the supply. I did also get some data from NHS Digital, just referring to that conversation around face-to-face versus telephone, which we know is kind of in the public eye at the moment. But certainly for June, the data I have for June shows that we had about 88,000 face-to-face appointments compared to about 55,000 telephone appointments across Vale of York. So I think we can confidently say that the number of face-to-face appointments with practice staff is certainly in the majority now compared to online and telephone type consultations. And obviously we'd like to maintain that position, but also we have to acknowledge that I think general practice has to adapt to new ways of working and digital access methods to be able to cope with that additional demand at the moment. And I think that, you know, there is something around telephone and online consultations can be managed more efficiently sometimes, basically freeing up a little bit of capacity for practices, which helps, and also freeing up some of the telephone lines for the patients that need to use telephone lines to contact their practice. So I think we need to keep this on as a risk in terms of reputational damage, particularly as we go into winter, because we are, I think, all in agreement that the system is under huge pressure at the moment. But I'll certainly bring back the updated numbers to future committees so we can see how those face-to-face appointments versus telephone are developing, and our overall kind of appointment numbers. Unfortunately, what it doesn't show is the additional demand that isn't being squeezed into the appointments that are there. Although we are trying to do some work to understand how that demand spills over into other parts of the system at the moment. And then the fourth risk, which again I think needs to be retained on the register, is the general practice wellbeing piece. And I know we've kind of spoken this afternoon around system being under huge pressure. You know, we're aware that some of our practices have called in Opal 3 recently because staff are starting to either contract COVID again themselves, or they have children who are having to self-isolate, so they're having to look after them when they're off school. So I think we absolutely acknowledge right across the system that our providers and partners are under a huge amount of pressure as we go into this winter with a huge amount of demand. And I think it's important that we do think about the well-being of all our providers, general practice included, and do what we can to try and support them through this. So I'll pause there. Happy to take any questions.
Okay. So the decision we need is that we remove the learning disability health checks from the register, yeah?
Yes, please, David, if everybody's happy with that.
Is everybody happy with that? And well done to the team for achieving that, which is really important, I think. Okay, any other questions, comments? Okay, so that's all you need, Sean, to proceed with the register, yeah?
Thank you.
Okay, let's move on to David Eiley and the NHS Improvement Primary Care report.
Hi everyone, I've been having a few IT problems, so hopefully this holds out while I go through the paper. So been mopping up on a few estates things, as you can see, for the items for decisions. So I'll go through each one. So the first one is one of the branches of Front Street Surgery at Cottonthorpe Shopping Centre. The landlord and the practice have agreed a 1-year extension to the existing lease to run until Christmas this year, which will give them time to discuss a longer term lease arrangement, which had been stalled due to COVID. So whilst acknowledging the original lease term has expired, the committee are asked to support the 1-year extension, noting there are no changes to the terms and that it will support ongoing discussions over a longer term lease. So just need committee support for that 1-year extension.
Okay, well, let's do that one by one, I think. Is that everybody in agreement with that? Okay, that's fine.
Great, thank you. Okay, the second one relates to Front Street Surgery. It's their main practice site. The existing lease is due to expire next year, and the landlord and practice have negotiated new lease terms, which have been reviewed by the district valuer. The new lease would be for an 18-year period with 3 yearly rent reviews. Once VAT and the lease term of a fully repair and insuring lease is factored in, the annual increase in rent reimbursement would be £3,125 additional to what's being reimbursed now. And whilst it's not written into the lease, the landlord has agreed £20,000 worth of investment into the property to improve the windows and guttering if the lease is agreed. So the committee is asked to approve the terms of that lease.
Okay, I suppose we should just check, Simon, that as we're moving through to agree these, that the finance is available and already in the schedule or affordable.
Yeah, I think that's the assurance that David's giving us. That's part of the delegated budgets.
Fine. Okay, thank you. Okay, so are we happy to approve item 1.2? Yeah. Okay.
Oh, okay. The third one is a rent review for the Aiken Road site of York Medical Group. The current site valuation for rent reimbursement is £101,600 per annum. And the rent review in question relates to an outstanding rent review from 2018. The district valuer assessed the property, and as of the 12th of May 2018, and determined the market rental value to be £107,500 per annum. Now, as it's above the delegated approval limit of £5,000 or 5%, it needs to come to the committee for approval. but it's protected by the fact the DV's assessed it and the premises cost direction. So the committee is just asked to ratify this one and approve the increase in the actual rent.
Okay, everybody content with that?
Yeah.
Getting nods all round.
And the final one, York Medical Group provides services from a branch site at the campus at St John's University. Due to a reconfiguration at the campus, the practice was relocated, and that prompted the need for a new rental agreement to be drawn up. The practice and landlord have drafted a tenancy at will, which would commence on the 1st of August 2020 and have 3 yearly rent reviews. The agreed annual rent is £20,538.92, and that was agreed between the practice and the landlord, which is higher than the current reimbursement of £16,600 per annum. However, the CCG would only reimburse the lower value of the actual rent or market rent once the DV had assessed the site, which we would do after approving the tenancy at will. So it'd be sort of worst case scenario that it would go up to that actual rent figure of £20,500, but actually the DV may assess it at less. So the committee is asked to support the draft tenancy at will.
Okay, is that supported? Okay, yeah.
Fantastic, thanks. And then just a couple of updates as well. PCNs were required to submit their workforce plans regarding the additional roles to the CCG, and that indicated, as we sort of touched on before, that there's 139 whole-time equivalent staff would be employed under that scheme across Vale of York by the end of the financial year. And 24 of the 25 practices in Vale of York, with the exception of Escric surgery, signed up to the 2 new enhanced services, the weight management enhanced service and the long COVID enhanced service. And that's everything. Thanks.
Okay, any questions, comments? No. Okay, fine. That's clear enough, David.
Thanks.
Okay. Well, we've whizzed through all that. In terms of key messages, pretty simply, I think that we've agreed to remove the learning disability health checks from our risk register, and that we've agreed a number of estates issues as detailed in the report from NHSEI. If Julie wants to look at the notes afterwards and make some more specific recommendations, we can do that. Is there any other key message that anybody would want to propose to go to the governing body? I mean, I think a general message from the meeting this morning is that, you know, I think we're all noting the amount of pressure and challenge that everyone in the system is facing at all levels, not just on the front line, at all levels, as reorganisation looms as well. So I'm sure that we would want to note that and note the possible effect that might have on patient services. But, you know, I think we're sure that everybody's doing their very best to ensure that that doesn't happen. So well done, everyone. Okay, well, there's a part 2 meeting, which I presume will be on Teams. So we need to come out of this meeting, and those that will be joining the part 2 meeting